Assalamu alaikum everyone, and welcome to our day 2 session of ECG Made Easy. I'm Dr.Sairah Sadaf, and let's start. So yesterday we just went through all these details of the graph paper, the electrodes, leads, wave formation, and progression of waves. And today we will be doing rate, rhythm, very important one, axis, and my most favorite topic, axis. Then hypertrophy, bundle branch block, and if we may have more time, we will go through the ischemia as well. So let's start. How to calculate the rate. Now, there is a method known as 300 method, or you can say a large box method. First, I will tell you how we do it, and then I will tell you why we do it. Let me draw it again. This is a P wave. This is Q. This is R. This is a very slanting R wave. And then this is S, T, and all that. Okay, now this R wave. When you want to calculate the rate, you have to look for the R wave that is at least nearly coinciding this, the dark line. And then you have to count the large boxes coming in between the two R waves. Let's say there is another R wave here. So now you have two R waves. You have two R waves. Now you have to calculate the large boxes, the number of large boxes in between the two R waves. Let's just consider this R wave is here. It's my okay. Let's just think that this R wave is coinciding or touching this black line, this dark line, and this R wave is touching this dark line. Okay. Now calculate the number of boxes. These are 1, 2, 3. Now what you have to do is you have to divide 3 on 3 on 300, and you will get 100. Got it? So let's say if there are let's say the R wave lies here. It's not here. Let's say R wave is here, over here. Now you have to calculate the boxes. 1, 2, 3, 4, 5. Now what you have to do? You have to divide 5 on 3. Like you have to divide 300 by 5. You will get 60. So it means the heart rate of the patient is 60 per minute. Got it? See this? This is the R wave. This is coinciding with this dark black line on the graph paper, or you can say the line of the large box. So just start counting. 1, 2, 3, 4, 5, 6, and 7. Let's say the second R wave lies here. If second R wave lies here, then we have number of boxes 1, 2, 3, 4, 5, and 6. Now we have to divide. You have to divide 300 by 6, and you will get answer of 50 beats per minute. Okay, you got this? As you all know, when we say the paper speed of ECG is 25 mm per second. Can you recall this? We have learned this yesterday, that the paper speed is 25 mm per second. 25 mm means 25 small squares per second. Yeah, it's same thing. Okay, if I say 25 small squares, or if I say 5 large squares, so it's the same thing. Yeah, 5 large squares. Okay, it's very slow to write on this board, with this thing. Yeah, now when we say 25 mm per second, we can also say that 25 small squares per second, or we can say 5 large square per second. So 5 large square. So if 5 large squares cross the paper in 1 second, so how many boxes or how many large squares will cross the ECG paper in 60 seconds? You have to multiply it with 60 and you will get answer 300 per minute. So that is the 300 we have here. Okay, it's easy. How we get this 300? Now, someone asked me that how to calculate when the rhythm is irregular. The method I have just told you, the 300 method, or you can say the large box method, it's for the regular heart rate. Okay. Now, this slide is for the irregular heart rate. What you have to do? You have to ask the ECG technician or ECG operator or by yourself, just take a 6 seconds rhythm strip. Okay. 6 seconds rhythm strip simply, and then count the number of QRS complexes or R waves in a 6-second rhythm strip and then multiply it with 10. And then you have to count the number of number of QRS complexes 1, 2, 3, 4, 5, and 6. Then you have to multiply it with 10. You will get the answer 60 beats per minute. So that's how you calculate the heart rate when the rhythm is irregular. Now, I have some hands-on or interactive slides for you. Okay, Ali Hassan is saying 33, Jennifer is saying 33, and Ali is saying 30. Okay, anyone else? Safiyullah 30, 32, Dr. Khizr 33. Okay. And all right. So your answer is 33. So let's see. Okay, Asma is saying 33. Okay, let's check the answer. Yes, it's 33. Good. So you know how to do it. Okay, now calculate here. Now tell me here. 1, 2, 3, and 4. Divide it on 300 and tell me the answer. Quickly, everyone. Jennifer is saying 75. Okay. Khizr 75. Huma, Kashif 75. Shayan 75. Okay, good. So you know. So let's go to Abdur Rauf is also saying 75. He's saying 76. Okay, 75 and Asma 75. Good. Okay. Now, let's see. Now, calculate here. It's very easy now. Number of boxes, 2 divided on 300 and you will get 150. Okay, everyone's saying 150. Good. Yeah, you know now. That's great. That's great. Yeah, 150. Good. Okay, now this is the test. This is irregular, first of all. Now, this is a 6-second rhythm strip. You have to count the number of the R waves. Sorry, not the R waves, the QRS complexes. And then you have to multiply it with 10. Now, what is the answer here? Okay, Khizr is saying 100. Jennifer is saying 120. Asma is saying 110. Asif, how 60? 110 and 120 are almost just like very close, but how 60? Okay, now let's check the answer. It's 110. Okay, now rhythm. Okay, rhythm is very easy. Two methods to identify the rhythm. First method is very easy. You just need to count the small squares between the two consecutive R waves. That's easy. You just have to see that the rhythm is regular or not. The dot method is what? First, I have to draw and then I can tell you. Dot method is way much easier and it's for the very new people. Like let's say this is R wave, this is R wave, this is R wave, this is R wave. Okay. What you have to do, you have to take a piece of paper. Now you have to take a piece of paper. You have to mark, make a dot here, make a dot here, and then just keep moving this paper on to match all the R waves. If all R waves just coincide with the dots, then you will say, yes, the rhythm of the patient is regular. It's easy. You got this? And the second one is you just have to calculate the number of small squares between the two R waves. If the number of small squares are same between every two R wave, it means that the rhythm is regular. This is my favorite one. And let's do it. Okay. Yesterday we have learned that the axis of the heart is the normal axis of the heart is inferior and lateral. Just now keep this in mind. There are a number of diagnoses you can make by knowing the left axis deviation or the right axis deviation, but the most common ones which we usually look for are the myocardial infarction, the very important hypertrophy, and bundle branch block. Same goes here. Infarction, hypertrophy, bundle branch block, and last but not the least is pulmonary embolism. Now, determining the axis. There are two methods of determining the axis, and my favorite one is quadrant approach, and I will teach you the quadrant approach. Okay? Because this is the easiest and very quickest, and you don't need to go into the like 30 degrees or 180 degrees and all that. The quadrant approach is very easy. You just have to look at the two leads and then you will like, boom, okay, you just reach the diagnosis. So we will go there. Now, determining the axis. What you have to do? First, you have to choose the two leads. These two leads are lead 1 and lead AVF. Now, someone of you may ask that why lead 1 and why lead AVF? I will tell you later. Just to know right now, just know that these two leads intersect each other and they are perpendicular to each other. Okay? Just keep that in mind. And both are in the axis of the heart. The other important thing. Both are in the axis of the heart. First, like lead 1, its direction is, as you know, current flows from right to left. That is of course, the axis of the heart. And AVF. And why AVF? Because it's inferior. And we know that the axis of the heart also lies inferiorly as well. Yeah, infralateral. So this is inferior, this is lateral. That's why we choose these two leads. And the other important thing is that these two are perpendicular to each other. Like it goes like this, 1, and AVF is like this, perpendicular to each other. And I will show you on my next slide. Okay. So when you are looking for axis, what you're doing actually, you have to choose the lead 1 and AVF. Then what you do, you look for QRS complex deflection, that it's positive or negative. We have learned previously yesterday that when we call it's positive, when QRS complex is predominantly, the R wave is more dominant. And when we say QRS complex is negative or it has negative deflection, when S wave is prominent. Or equiphasic is what? When both waves are almost equal. When both the waves are positive in lead 1 and lead AVF, we will say the heart has normal axis, or the axis of the heart is normal. Now, I will come back to this diagram again. First, I will tell you what is axis and how do you just identify the axis. Now, look at this diagram, this picture. You want to take a screenshot? Just take a screenshot. Now, you're having the ECG where both the lead 1 and AVF are positive, or you can say it has a very prominent R wave or dominant R wave. So it is positive. Now, how to draw it? Let me draw the two leads on graph paper. Let's assume this is a graph paper. Okay, this is a graph paper. Now I will draw both the leads. This is our lead 1. It is the lateral lead. This is the negative pole. This is the positive pole. Now, this is our AVF downwards, the axis of the heart. This is negative pole. Not like pole, but you know that as it goes down, because so that will be the positive. As it is going towards the electrode placed here on the foot end, so it will give a positive deflection when it goes downward. Yeah, got it? So these are the two leads. This is a lead 1, this is lead AVF. As I have said that R wave is positive, R wave is positive. So where are the two positives here? This is the positive, see? This, okay? And the other positive of lead AVF, let me write here AVF. Okay, this is lead AVF. Okay. Now, if we say, so this is the normal axis of the heart. Okay? Normal axis deviation. Basically, it's not deviation, but I'm just writing it in the way like it's a normal axis of the heart. Lateral and inferior. Got it? Now, let's move to the second option here. Now you have ECG where in lead 1, there is a positive deflection. The R wave is more dominant. While in AVF, there is a negative deflection. In AVF, there is negative. Now let's draw it on our graph paper. Lead 1 is positive. So it's here. Okay. Lead 1 is positive. It's here. Now, where's the negative end of the AVF? This is negative. AVF is negative. So where's the negative end of AVF? Here it is. Yeah. So what is that? This is the left side. It is known as left axis deviation. All right. You got it or not? Do you understand that? My dear students? Okay. Jennifer is saying, got it. Alina, got it. Got it. Got it. Yes, ma'am. Okay, good. Okay. Everyone got it. Okay, cool. Okay, that's fine. That's good. Okay. Now let's move to the right axis deviation. Now, as you can see that in lead 1, now it is negative and AVF is positive. See, here S wave is deep and here the R wave is dominant. So it is negative, which is positive. Let's draw it on the graph paper. Now, the positive end of the AVF is this. Yeah, this is AVF, the positive end of AVF. Where is the negative end of lead 1? As we can see here, this is negative. So where is the negative end? Here is the negative end. And as you can see, this is the right side. So we will say it is right axis deviation. Okay, easy. Now to the extreme case where both the waves, the waves in the both leads are negative. In lead 1, S wave is prominent and dominant, and in AVF, S wave is dominant, which means that both are negative. So where are the both negative ends? Of the negative end of lead 1 is this, and the negative end of AVF is this. So this is the extreme axis, and we have another name for it. I will tell you. So it is the extreme axis. Okay. What's this another name? Its another name is over here. It's a northwest axis. Okay, we call it northwest axis. Now you have to tell me that which axis. Now which is which axis? Okay, it's your turn now. Okay, coming to your here. When in lead 1 and AVF, we have both the positive deflections. Then what axis it is? Now everyone tell me in the chat box. Jennifer, normal, Safiullah, normal, Alina, normal, and Khizr, normal. Yes, it is normal. And Asif, normal, Samia, Batul. Yes, everyone good. Yes, cool. Okay, so this is a normal axis. Yes, you're right. Okay, now, which axis is the next one? When in lead 1, it is positive, and AVF, it's negative. So which axis is this now? Yeah, Jennifer is saying left. Everyone left. Okay, my chat box is getting full. Yeah, it's left. Good. Yes, it's left. Okay, left axis deviation. Now, which axis is this? Where lead 1 is negative and AVF is positive. Now, which axis is this? Dr. Hani saying right, Aruj right, Jennifer right, Khizar, Huawei, Asif, Alina right, Safila right, Saima Batul right, Myra right. Okay, you all are right. This is right axis deviation. And the last one is, you all know, northwest extreme right. Good. So I'm happy that you just know this now, and you just simply understood it very well. So well done, great. Now coming to this slide, this is very important. Okay, when you examine the QRS complex in lead 1 and AVF to determine if they are predominantly positive or predominantly negative. Now, when we have left axis deviation, in case of left axis deviation, you need to examine lead 2. Okay, I will repeat. When there is left axis deviation, in case of left axis, you need to confirm whether it's pathological or non-pathological. If in lead 2, Cure's complex is predominantly positive, then left axis deviation is non-pathological and it's normal. But if in lead 2 it is negative, then the left axis deviation was inactual and it is pathological. Got it? When you found there is left axis deviation on ECG, when you find out that there is left axis deviation on ECG, you have to confirm it on lead 2. If it's also negative in lead 2, then it means that it's pathological. There's really some reason behind it. But if in lead 2, it's not negative, the R wave is positive in lead 2, then it means that it's normal. You don't need to worry about it. Let's practice for the axis deviation. Now, everyone tell me, just inbox me that which axis is this? Okay, now tell me which axis is this? Who is saying normal? Dr. S, this is not normal. Alina is saying right. Khizar right. Safila is not extreme. It's not extreme left or what. It's right axis deviation. It's right axis. Okay. Let's check. It's right axis deviation. Okay. Now, which axis is this? Adnan is right. Saima is right. And Hani is right. Khizar is right. Alina is not extreme. It's Aruj is right. It is right axis deviation. It's not left axis because look, lead 1, there is S wave, and in AVF it's upright. Okay, it's the right axis deviation. Okay, let's go further. Now tell me which axis is this? The AVF is negative and lead 1 is positive. Now tell me which axis is this? Okay, we have a lot of lefts here. Yeah. Khidr, Jennifer, Adnan, Huawei, Dr. S, Safila, Myra, Sadia, Aruj, you all are right. Ali, you're right. Alina, Adnan. Okay, Adnan is saying as lead 2 is pathological. Yeah, yes, yeah, you're right. Good. Left axis deviation. Now you have to confirm whether it's pathological or not. Then you have to look into the lead 2, which again it's negative. So it's a pathological left axis deviation. Well done, Adnan. Yes, you're right. And sir, my dear teacher, Professor Akdal Durrani is also saying it's pathological. Yes, sir, it's pathological. Now tell me here. Now see, lead 1 is negative and AVF is positive. So which axis is this? Right axis. Okay, everyone. Now you got it. Great. And I'm happy that you understood it very well. It's right axis deviation. Now, which axis is this? Jennifer is saying left. Yeah, it's almost left. Left non-pathological. Okay. Left pathological. Let's see it's pathological or not. Left. Okay, let's see the answer. It's non-pathological. Yes, very good. And Dr. Okay, Adnan was saying it's left and non-pathological. So well done, Adnan. Yes, you're right. Now, okay, just tell me quickly which axis is this? Left. Jennifer, is this left pathological or not? You have to comment fully on it. Yeah, everyone is right. Left pathological. Yes, well done. Yeah, it's left and pathological. Why? Because it is also negative in lead to. Good. Left and pathological. So we have another here. And now I will tell you this is the positive, this is a negative. So this is again the left axis deviation and it is pathological because it is negative in lead to. We have another ECG. In lead 1, it's positive. Where's AVF? Yeah, it's negative here. So it is left axis. And we have negative deflection in lead 2. Again, we have pathological left axis deviation. Okay. Okay, now that's really cool. So everyone of you now knew very well and understood it very well that how to determine the axis of the heart. Dr. Durrani is saying first time came to know. Great. Okay, sir. Thank you so much. Thank you so much, sir. What is hypertrophy? Hypertrophy is the thickening of the ventricular muscles. Okay. And now left ventricular hypertrophy and right ventricular hypertrophy. How we can suspect that patient is having left ventricular hypertrophy or right on ECG without doing echocardiography? We can do echocardiography later to confirm our diagnosis or confirm our suspicion. Okay. Let's do it. First of all, if there is left axis deviation on ECG, okay, Haris was asking what's the use of axis determination. So this is the first use. Left axis deviation, R wave and S wave both combine, when we add the small spheres of both, if they are more than 35 mm, there is ST segment depression or there is asymmetrical T wave inversion. You can say the patient is having left ventricular hypertrophy. And we have something else most frequently seen with hypertension. Now, right ventricular hypertrophy. We may have right axis deviation, and we may have all this. Okay, let me tell you one by one. V1, there is tall R wave, like more than 7 mm, or in V6, there is deep S wave, more than 7 mm. Or if we just combine the small spheres of both and they are more than 10 mm, we can say the patient is having right ventricular hypertrophy. Or there's also a few more things like RS ratio. RS ratio means if the R wave and S wave are equal in lead 1 or lead V1 or lead V6. Okay. Okay, what's next? And then there is RSR pattern, maybe secondary ST depression, as we have seen in the LVH. Usually will be seen with the pulmonary pathology. Okay, got it? So it's clear up till now. If it's clear, I will move to my next slide. Let me draw the lines. This is the normal ECG, and this is the ECG with LVH. And this is the RVH. Okay, now you have to look into the lead V1 and lead V6. V1 and V2, these usually represent the right heart, while V5 and V6 represents left heart. When we look at ECG in the lead V1, we have, in the normal situation, we have a deep S wave And in V6, we have a tall R wave. Okay. So what happens when there is hypertrophy of the heart? In case of LVH, the S wave will deepen, further deepens in V1, and R wave becomes further taller in lead V6. And what happens in RVH, right ventricular hypertrophy? You have to see this one. This one is good. Okay. Normally there is S wave in V1. Yeah. But when there is right ventricular hypertrophy, the things will get opposite. The things will be opposite. There will be no S wave or a small S wave, and rather there will be a tall R wave. And in V6, again, the things will be opposite in case of RVH. Like as you can see, in V6, normally the R wave is tall and there is a very small S wave. So when there is RVH, in the case of RVH, you will be having a deep S wave and a small R wave. Now I will repeat this thing in another way. In case of left ventricular disease, the normal findings will get enhanced. And in case of right ventricular disease, the findings will be opposite to the normal. Now you got this thing? I will repeat it again. In case of left heart diseases, like left ventricular hypertrophy, say, the normal findings or normal features of ECG will enhanced. Like if there is normally there is S wave in V1. So in LVH, in V1, there will be, of course, the S1 wave, the S wave will be there, but it will be more deepened. And normally there is R wave in V6. So in case of LVH, it will further get enhanced. But in case of right ventricular diseases, the things will get opposite. In lead V1, there won't be any S wave. There will be R wave. That is the opposite of the normal phenomena. And again, coming to V6 lead, there will be a prominent S wave, a deepened S wave instead of R wave. Okay, got it? Just inbox me so that I know that you just understood it or not. Okay, everyone's saying got it. Okay, good. So that was all about the hypertrophy of the heart. Now you will identify which hypertrophy is this. Now come on, I have another exercise for you all. Tell me, everyone, just inbox me. As you can see, yeah, usually there is S wave in V1 and R wave in V6. So these are the normal findings, but these are enhanced. So these are enhanced. So it may be LVH. Yes, you are right. Okay, tell me, what is this? Just look at this. This is we have to look at the V1. This is V1. This is V6. Now look at this very closely. There is S wave in V1, while here there is R wave. See, this is R wave. This is opposite to the normal. And usually there is no S wave or small S wave, but as you can see, there is S wave present in V6. So it is, yes, you all are right. This is RVH. Good. And of course, as you can see, there is right axis deviation as well. RVH, you all are right. Let me clear it. Now tell me, what is this? In V1, this is S wave, that is normal. I mean, normal, by saying normal, I mean this is a normal feature, but it is enhanced. It is enhanced. And in V6, there is R wave, but that is a normal thing, but it is more taller. And then we have left axis deviation here. So it is LVH. Yeah, everyone, right. This is LVH. No, we're not taking a break. We will go to the bundle branch block. Okay. bundle branch block. When we look for the bundle branch block, we have to look in lead 1, lead V1 and V6. In hypertrophy, we just look in the leads V1 and V6. Now, when we are looking for the bundle branch block, we have to add lead 1 also. Okay. And the other thing is V1. Okay. The other thing is the V1, lead 1 and V6, they will be same and V1 will be different. Okay. The findings in the lead 1 and V6 have to be same and V1 will be different from the above, from 1 and V6. First, just make this thing clear. And the other thing, as you can see again in the left bundle branch block, as I have mentioned earlier, that in the left heart diseases, the normal findings are enhanced, while in right heart diseases, the normal findings got opposite or get opposite to the normal. Okay. So if you can see here, the S wave is a normal finding of V1 and R wave is a normal finding of V6. But there is a little deepening and broadening of S wave in V1, and then there is a broadening of R wave in V6 with T wave inversion. And this will also be seen in lead 1. So this is left bundle branch block. In case of right bundle branch block, there will be again the opposite of the normal findings. Like as we know that usually there is no R wave in lead V1. But in case of right bundle branch block, there will be, not only there will be R wave, but it will be in the shape of M. It's also known as RSR pattern, RSR or M, and it will be very broad. So this is right bundle branch block. And as we know, there is usually no S wave or small S wave in V6, but in case of right heart pathology, right bundle branch block, S will, there will be a prominent S wave and it will be very wide in V6 lead. Now, as you can see, this is the normal one. This is RBB and this is LBB. Okay. Now, see here, this is a normal ECG. This is V1 and this is V6. Okay. This is S wave. This is prominent R wave, a normal, this is a normal thing. Now, in case of RBB, first let's go to the LBB. Now, in case of LBB, as I have mentioned, the normal features will get enhanced. So there is S wave, but it is more deeper and more wider, and it will make a shape of W. You can see there is a slurring. There is a slurring in the QRS complex. And in V6, it's the R wave. That is a normal thing, but its shape is not normal. It is more wider, more taller, and there is a slurring here. It's making M. It's making W here. It's making M, also called the slurring of the QRS complex. So this is a normal features, but these are enhanced. This is LBBB, left bundle branch block. While in case of right bundle branch block, as we all know, there should be a normal S wave, but in case of RBB, there will be a prominent R wave, or sometimes there are two R waves, giving it a shape of M. Or you can say a slurring, a little slurring of the QRS complex. There will be R wave in V1 lead, more taller and broader, wider, and with a slurred tip, And when we will be looking in the V6, there will be a prominent S wave, broader and deeper, and there will be slurring in the QRS complex. Okay, this is RSR pattern, RSR, also known as slurred QRS complex. I hope I have made it clear so far. Here's an exercise for you. Just look at V1 and V6 and tell me what is this. And if you look at lead 1, there is a slurring here, and it should correlate with the V6. Both are same. Now, this is the normal finding. Yeah. As we all know, this is the normal finding, but it is broader and there is a slurring here. Can you see this? This is broader and there is slurring here. And again, in V1, there's S wave, normal, the S wave, yes, S wave is here. It is deeper and it is broader. So what is this? LBB. Okay. Yeah. This is LBB. Okay, now look here. Now you have to tell me what is this. As I have mentioned, as you see, this is the slurring. And it is known as RSR. There is small r, there is small s, then there is large R. See, this is small r, small s, then again large R. It is known as RSR or WM pattern. And again, we can see this here. So what is this? RBB. Yes, everyone, you're right. Okay, now what is this? This is very clear now. The normal features, but enhanced. Broader, taller, deeper. This is LBB. Yeah, everyone, this is LBB. Good. Okay, now what is this? Now, next slide. Now we have MI also. ST elevation. There's also ST elevation in. Okay, now tell me what is this? The normal features and they are enhanced. And the second thing, it is LBBB with acute MI. LBB with MI because there is ST segment elevation as well. Everyone, you are right. Okay, now what is this? Very beautiful ECG of. Come on, tell me, what is this? Opposite to the normal findings. There is R wave that is opposite to the normal. There is deep S wave and broad S wave that is opposite to the normal. So it is RBB. Yeah, you're right. Yes, everyone, you're right. Okay, now what is this? The features, these are opposite to the normal S wave and there's R wave in V1. So this is again RBB. Yeah, these are the normal findings. These are enhanced. As you can see, this is the slurred R wave here, taller. There's a normal finding, but enhanced. So it is LBB. Yep, you're right. And we're done. Okay, thank you so much, Jennifer, for your lovely comments and appreciation. Thank you. Okay, let's do it now. This is ischemia. The different types of ischemia. This is the normal ECG. Whenever the ST segment is deviated from the baseline, we have to see that either it's going downward or it's going upward. To label it ST segment elevation ischemia or non-ST segment elevation ischemia or ST depression ischemia. Okay, that's very easy. Now, as you can see, it is deviating from the baseline. It is ST depression. It is also deviating from the baseline going downwards. It's ST depression. Now, this is the elevation, ST elevation, and this is a very simplest form of ischemia that is not have only finding, that is T wave inversion without any ST elevation. If there is elevation in V1 and V4, you can say there's anteroseptal MI, okay, or anterior wall MI. These are the lateral leads, 1 AVL, V5 and V6. So it is known as lateral wall MI. When we call it anterolateral, when along with these, we also have V1 to V6 leads as well. So these are anterior and lateral wall MI. V1, V2 or V1, V2, V3, V4 are the anteroseptal MI. These are the inferior leads, lead 3, 2, 3 AVF. So we call it inferior wall MI. Okay. And you can take a picture of this slide or you can take a screenshot, because this is very important slide. Sometimes you got question in the paper regarding asking if there is the lead V1 is involved or V2, so which artery is blocked. So you must know that. Okay. Now you have to take the screenshot, and I will move to our next slide. Okay, this is again different shapes of ischemia. I'm not going into the detail. The most important thing was this. You should know this, that when which lead, ischemia in which lead, or the elevation in which lead means which wall of the heart is involved. Now here I have some ECGs, and you will tell me that which wall of the heart is involved. And with that, our session will end. Okay. So these are the last slides. Now you have to see which wall is this. Like you can see here, V1 is here, V2, and then there is lead 2, lead 3, AVF. These are the inferior leads. And then there are V1, V2. Inferior. You are saying inferior? I think it is more than inferior. Just look hard. Look, there is lateral leads are also involved. Inferior leads are involved. Then there are anterior leads are involved. It will be, okay, you are saying infralateral septal, anterior, inferior, lateral. Okay, let me see what is it. One more in AVL, V5, V6 is also first. These are the lateral leads. Now also in the V3, V4, these are the anterior leads. So let's see what is this. So what is this? In my opinion, it looks like, yeah, okay, you're saying anterolateral. Yeah, it looks like anterolateral. Oh, yes, it is anterolateral. Yes, you all are right. Everyone is right. Now, what is this? Mostly saying anteroseptal, yes, anteroseptal, and let's see inferior is involved or not. It's anterolateral, yeah. Sometimes there's a reciprocal changes in the other leads. So it is more on the anterolateral side is affected. Now, which one is this? V1, V2, V3, V4, in V5, there is ST elevation. Some part of lateral wall is also involved. Okay, you're saying anterolateral. Okay, you're saying anterolateral? Someone is saying septum, anteroseptal. Okay, let's see what is this. This is anterolateral. Okay. When there is when there is involvement from V1 to V4, then we will not say anteroseptal. We will just say anterior wall. Okay. When there is involvement of leads from V1 to V4, we don't need to mention separately septum. We will just say as a whole the anterior wall MI. And now there is lateral wall as well. So we will say anterolateral. We will not say enteral, septal, and lateral. Okay. This is anterolateral again, because the lateral wall, 1 AVL, and from here the V1 to V4 anterior wall. So this is anterolateral. So this is, hopefully this is last one. Oh, this is last one. Okay, now. Okay, over here, lead 1, AVL. These are the lateral leads. And other leads are clear. It looks like the last, now this looks like what? It looks like only lateral wall ischemia. This is lateral wall ischemia. Okay. Okay, that's all for today, everyone. Little revise access if possible. Please, ma'am, upload this lecture on your YouTube channel. Yes, inshallah, I will. I will definitely upload it here. No, Jennifer is asking, ma'am, in bundle branch block, we don't check lead one very quickly. And if only check V1, V6, is it okay? Yeah, that's totally cool. That's totally cool. You can just look at the findings on the V1 and V6. But if you want to be more careful, just also check lead one as well. Okay. Ali, what you're asking? I have lost your question, Ali, in all the rush of all the rush of these comments. I have lost your question. What are you asking? I have lost you. In bundle branch, do we have to check only V1 and V6? I have already answered this. This is a beautiful ECG of RBB. Now, how come I can say this is RBB? You have to answer this. Let me open the mic for you. Now you can talk, okay? Ali, now you just unmute yourself and just talk to me.
मैम V1 में ऑपोजिट पैटर्न है, एस वेव की बजाय अब हमें आर वेव मिल रही है, और V6 के अंदर आर वेव की बजाय हमें एस वेव मिल रही है और वो ब्रॉडर भी है। और यस मैम,
सो ये आरबीबी है, ठीक है?
ये
Okay.
आरबीबी है। यस
So this
मैम।
is RBB.
Yes.
So now you understand. So now you understood this all or not? Still confused or
यस मैम।
now you
यस
got it?
मैम, थैंक यू सो मच। अब समझ लगी।
Good, good. Okay, then everyone, I have shared my shared the link of my group. Just give your feedback and you can ask your remaining questions in the group. Okay. Thank you so much, everyone, and Allah Hafiz, and see you tomorrow right the same time.